Good morning, everyone. This is House Healthcare, February 5th. And this morning, we are going over the budget. We're going to start with central office, AHS, and then move into DEVA. And we have with us Secretary Samuelson. Take it away.
Good morning. For the record, I'm Jenny Samuelson. I'm the Secretary for the Agency of Human Services, and we're here with our executive leadership team, including our Chief Financial Officer and the commissioners from each of our departments.
Yes, and for the record, I'm Tracy O'Connell. I'm the Chief Financial Officer for the Agency of Human Services.
And Chair, do you prefer that we take questions throughout or wait until the end?
I would say let's take questions throughout, but we'll try to keep them contained.
Right. I appreciate everyone's willingness to have us in. I know that you've had a couple of the departments from our agency and already felt like it was really important this year to ground everyone in the process that the agency went through to create our budget. As a reminder, the Agency of Human Services includes both the Secretary's Office and 6 departments, the Department for Mental Health Access, the Department of Health, Department for Mental Health, Department for Children and Families, Department for Disabilities, Aging and Independent Living, and the Department for Corrections. Overall, our budget as proposed is $3.75 billion. The agency is the largest agency in state government with a little over 4,000 employees. This identifies where those employees sit within the agency in our current vacancy rates. For our budget this year, we are looking at as proposed, an increase of $86 million or 6.1% increase in general fund based budget. That's an increase of 5.3 general fund for direct services to keep our current services going. So, but you'll hear throughout the process, what we did was identify what is it that we need to keep the lights on first, and that's this first bucket. The second bucket are a small number of initiatives that support our broader priorities, and those investments are $11.2 million. Okay. Our executive leadership team. So the agency executive leadership team includes myself, the deputy secretary, and the commissioners in each of our 6 departments. This is important because the executive leadership team was foundational this year in creating our budget and doing it through a new process. So in the past, the way that the budget has been done at the agency is that typically we get a target amount of funding that's available to the agency. The agency then gives a target to each one of the departments. And then those proposed budgets in the past have come up to the Secretary's office, and the Secretary's office was often the one that would arbitrate the decisions between the departments. What we saw are at times one department cutting a service in their department that has significant impact on another department without actually coordinating between departments. If we are really working as one agency and optimizing the fact that these 6 departments are in one, it really should be acting as one program. We reset this year and really established that for each of our executive team members, not only were they commissioners of their department, but they were the executive leadership team for the agency. And what that means is really looking at what are our priorities, how are we allocating resources for that, what are our policies and protocols across our agency versus a department by department. So this year for our budget process, we looked first at the governor's priorities. These won't surprise anyone: growing the economy, making Vermont more affordable, and protecting the most vulnerable. That executive leadership team then took a step back and said, what are our priorities as an agency for this next year? And really, these also won't surprise you. It's housing with a particular focus on homelessness, substance use, and mental health across the full spectrum, including prevention, treatment, recovery, and stability. And in particular, really working to create a co-occurring system of care that works better for the clients that we serve. Healthcare affordability, sustainability, and quality, and a strong and resilient workforce. What you will see is our budget is aligned to these priorities and continuing the operations of the agency as a whole. In addition to setting those priorities, the executive leadership team did something that we haven't done in a really long time. We took a look at the programs that were federally required. We also took a look at the effectiveness of each one of the programs based on data. How many people were they serving? Were they getting the outcomes that we are intending? What was the cost of the program? What would be the impact of any programmatic changes? Really to determine, are there programs that have existed over time that are no longer serving the purpose or are duplicating other services? We started with with the foundation of our Medicaid program because that's the majority of the budget at the agency, but we also went out department by department and asked them to evaluate their programs. We also evaluated the alignment of the AHS budget as proposed to the priorities and the effectiveness of programs in order to make the decisions. Brian?
Before you go ahead, I just wanted to ask a question about the process. The first thing it looks like was the governor's priorities. Were they considered in that order? Like, was the first priority growing the economy, and the second one making Vermont more affordable, and the third one protecting our most vulnerable? Meaning, like, was growing the economy more important than protecting the most vulnerable?
We didn't tier them and
You didn't.
we
Thank
did
you.
not.
Thank you.
Okay. So we took it, as we looked at it, we took an inventory of the budget process. We started with our target as we usually would. We took an inventory of our current services and projected cost increases in order to keep the lights on at the Agency of Human Services. Initially, that was an overall budget increase of $117 million. The target for the agency, and I think folks have been transparent about this across state government, was a 3% increase. If that 3% increase netted out for the agency a $42 million potential increase, you can see that there's a lack of alignment of about almost $75 million between those two targets. The departments each came forward, going back and looking at that evaluation together with potential programs where they could see savings and reductions, and also potential government efficiencies within our own agency where we could see savings and reduction. We focused on identifying revenue offsets. Where could we bring in more revenue? We looked at administrative and programmatic efficiencies. And we also looked at the evaluation that I talked about, and specifically which were non-essential, non-mandatory programs that weren't statewide, programs where there was duplication. Oftentimes there's been creation of programs that over time conflict. For example, with the emergence of mobile crisis, we've seen that have duplication with some other types of services, and those that were less effective in not getting the outcomes.
So as the secretary said, our initial bogey, if you will, that we had to cover was 117 million. When we sharpened our pencils, it got down to 115.8 million in this budget. The two biggest areas are in the revenue loss category and caseload and utilization, and then you can see the other areas. So we'll provide an overview over the next few slides on the different areas that we were seeing some pressures. So the first big category is the backfill of lost revenue. So this is where we are receiving less federal funding or less special funds in the state, and therefore we need to backfill with general funds. The first one is the base FMAP change. That's the federal medical assistance percentage that Medicaid matches the whole Medicaid program. And so it went down 0.73%. And so that equated to $13 million in general fund that we needed to backfill the lost federal revenue. And that FMAP change, that changes every year, and it has to do on the nationwide basis. And so every state, some are set at the standard 50%, but right now we are at 50.
So I think the key important point about the FMAP this is not anything that has changed at the federal level. It's that they use the same calculation that they use every year. It is a normal thing for us to see slight swings up, which we've experienced over the last couple of years. And we are actually at a very high FMAP compared to where we have been. And sometimes we see slight changes down. So this is not anything that has changed anywhere at the federal level, but is a normal part of the Medicaid program.
Is this $13 million in, is it just our typical FMAP or it is 5842, something like that?
5807.
It's not that 13 million isn't influenced by like loss of new adults or.
No, in fact, that is to our favor in this budget cycle. Yeah.
And so that's
Yeah.
a question we often get, and I just want to make it really clear. This is a normal part of our Medicaid program. You know, years ago, our FMAP rate sat around 54%. We are at over 58%. So we're not shocked or surprised to see that start to moderate out.
Can you remind me what the enhanced FMAP was with COVID back? Well, do you remember? I know it's burned in your brain. I guess it's not burned in your brain.
Get back.
Should be burned into my brain. It's not. I can follow up on that. 2.2? What is the 2? Well, we'll follow up. That's a good question.
I have a number, but I'm not.
Yeah.
$1 million a quarter or $8 million every half year, right? So
I just didn't know if with the increase and what that rate was at the time, where it netted out, is it around 58 or was it higher than that?
It's gone up.
We can supply a chart. We have the chart with the bump.
And it's gone up
Yeah.
over the last 2 years to our favor.
Yeah.
The next area is with SNAP admin, with HR 1, the federal matching rate for those costs was 50/50, and now it'll be 25/75. So the federal government will only be matching 25% and the state will have to kick in 75%. And for this budget cycle, that's a backfill of $4.5 million.
And that will go up next year because that's only a portion of the year. That's for the federal fiscal year.
And then,
Sorry, and this is for the administration of it. I know there was also a piece about error rate.
Vermont is in a great position on error rate. The error rate is at 6%. And beyond that, there's a penalty to states. We are well below that 6%.
Okay, so this is just for the administration of it.
This is just for the administration.
and then with the Child Care Special Fund, where the economist projected a revenue downgrade due to the collection of the payroll tax. The receipts just haven't been reaching the level that was appropriated. And so we're seeing that we have to backfill $8.7 million of the special fund with general fund. And then in the next area of caseload and utilization, it's about $27.8 million general fund. And a lot of this is what you saw in budget adjustment. So it's the Medicaid consensus, caseload and utilization, clawback and buy-in, developmental services, and the Choices for Care program, both nursing home bed days and HCBS. Next area is salary and fringe for the entire agency is $21.3 million. We did include a request for about a $500,000 general fund to support 12 new KU staff at DIVA to support the Medicaid work requirements and the biannual redetermination work that needs to occur starting next year.
And those are 12 positions dedicated solely to.
There are 12 positions dedicated to eligibility enrollment for the Medicaid program. This is again, it's the new adults, so it's not the entire population of Medicaid that's going to have to redetermine every 6 months.
Yeah.
This is what we believe that we will need to increase in terms of our eligibility and enrollment staff to accommodate that.
Can you remind me how many people currently are in redetermination and enrollment? So.
Yeah, for as part
For
of
the record.
the new this Deshaun Rhodes Stupid Commissioner. For the new adult population, about 5,000.
I'm sorry, how many staff?
How many staff?
Yes, how many staff currently?
It's about 100 over 100 FTEs.
So it'll be 112, is that what you're, for how many, and the size of the population this group is addressing?
So we don't, we can have Addie Sturmelo, the deputy commissioner, will come in when we testify after this.
Yeah, I should have left that question too.
Oh, in my head, it was something.
I think they'll go over it in
Yeah.
Diva's budget.
Diva's budget, we won't fund any of those things. Diva will be in right after us, and so this gives an opportunity to take a look at that.
And then we had $6.5 million for operating expenditures, most of that the internal service funds, which is BGS, HR, ADS, the insurances, 192,000 for the Pilgrim Park.
What is that?
Pilgrim Park is the lease.
Oh, lease.
Yeah.
You said peace, I'm sorry. Park Peace.
It's a
Okay, I
lease.
get it now.
And about $1 million for operating expenditures at DOC.
$5.1 million increase for like ADS and
ADS is a portion of that, and so you'll actually see somewhat of a corresponding decrease to an ADS portion, the ADS service level agreement. So ADS has changed their model. So some of the services that were in the service level agreement have now migrated into their core enterprise service back charge to us. So there is a somewhat of a decrease further on in the presentation.
Does that include access to ChatGPT?
That is a service we receive.
Good. All right.
We're seeing about $17 million increase in contracts. A lot of this was already in budget adjustment. So the Diva, Gainwell, MMIS vendor, the Maximus call center, and our Medicaid data warehouse, transportation in DMH and DF, forensic valuations at DMH, and also the travel nurses, $1 million for the Wyndham Youth Crisis Stabilization, the WellPath increase related to the average daily population that DOC is experiencing, and the transition. Oh, this is a new thing that it was not in budget adjustment, but we're backfilling $247,000 for a transitional housing program through the Burlington Housing Authority. They lost some federal. Yes. We're also annualizing some multi-year programs that got started in the 26 budget, but they were only for maybe a partial year. So for example, the Medicare Savings Plan that went live this past month, January 2026. And so this will annualize it for a full year. We're also annualizing alternatives to emergency departments with DMH and some shelter investments that we had started with one-time funds that we are seeking to build in the operating costs into the base for DCF. And there are some provider rate increases. One is the Northeastern Family Institute, about $252,000. In DIVA, there's the federally required increase for FQHCs and RHCs that's tied to the Medicare Economic Index. The PNMI inflationary increase at DMH and DCF, that is according to state rule. And with the DMH, the CCBHCs, they will be expanding to 5 new designated agencies starting in 27. And then for Dale nursing home inflation, which happens every year.
And it's a required rate increase.
Required.
So that's the theme here. The rate increases are required rate increases.
The NFI increase, is that for the hospital diversion programs? Is it for the group homes? Is it for the whole agency?
The hospital diversion.
Thank you.
oh, Tupper.
Can you go back to the page before that? On the corrections department. WellPath,
Yes.
5.6 million.
Yes.
Are they ICE detainees? I mean, what,
So what we've seen is an increase in our daily census in the Department of Corrections. Many of them are, the majority increase in that are in the number of detainees generally in Vermont. So individuals who are picked up and then detained before they have an opportunity to go to court. It does not have to do with the ICE detainees. It is a general increase in the number of people coming into our system, and particularly detainees.
Is that due to court backlogs?
I think we can get into that in more detail in another place of space. It will, because it will create many more questions. That is both an increase in the amount of people who are coming into the system and are waiting, but more than anything, it's an increase in the number of people who are being picked up.
I see.
And-
Here's what you're seeing.
I should say. So a lot of the time people are picked up and then they go out on bail while they're waiting for their court. These are individuals who are being picked up
Waiting.
and waiting trial.
Brian has a question, but it something I've never thought about. So, I mean, we do have ICE detainees in some of our correctional facilities.
We saw a significant increase in their contract this year to cover the cost for those detainees.
Okay, I was gonna say, does the state have to pick up through WellPath?
They are served by WellPath, but and again, we can get corrections to come in and provide more information. Most of our commissioners are here for representing our executive leadership team. But in this case, last year, we saw a significant increase in the rate that is paid for under the marshal's contract for the cost per person for individuals who are detained who are here in Vermont.
And the state is being reimbursed for
The
that.
state is being reimbursed because the amount that the federal government pays the state increased significantly.
Okay, go ahead, Brian, I'm sorry.
I'm also curious, and if we can't get into it today, because it looks like you have a lot to cover. I'm curious about the impact of homelessness on the increase in incarceration, because something we saw on the ground is when it got cold, some people intentionally committed crimes and others, the governor kind of sent in the cops with the mayor and rounded them up. And so a lot of people are in jail right now who would have otherwise been homeless. So I'm curious how much that's driving the expenses, because a lot of them have health conditions.
I don't want to create conjecture here. This is actually just a increase in the total number of people who were incarcerated. Anybody who was picked up in Burlington through the accountability court had 5 or more dockets that were pending. So this was a way to address the court backlog. We have not seen it create a significant increase in the number of people who are incarcerated. So I just want to clarify the record on that. In Burlington, what we essentially did was individuals who had 5 or more pending dockets, which is a lot. They prioritized in the court system to address, Chair, what you had brought up. It wasn't a roundup. It was moving the court system more effectively and faster. Okay.
Thank you.
Daisy, Daisy has a question also.
On the last slide. Yeah. Under provider rates, am I interpreting this correctly that at all of those line items under this 6 million bucket, provider rates are increasing by 6 million?
Provider rates, yes, that is correct.
The general fund
So,
portion, so actually it's even more on the gross side.
Okay, because I'm confused why with the addition of 5 CCBHCs, there's only a 2 million up.
Yeah, it's on the gross level, it's more like 6 million, I believe. Yes.
And can you relate that 2 million to a cap on salaries? Is this related to that? Is that why we're only paying staff at CCBHCs a limited amount because of the amount that we have in the general fund to match the federal?
And I think CMH can come in and provide more of a drill down, but I
Yeah,
wonder,
it's not,
Commissioner, for the record.
for the record, Emily Haas, Commissioner for the Department of Mental Health. Thank you, Jenny, for reminding me to introduce myself. So with the CCBHC dollars, that's a mixture of what's in the current case rate that's allocated to those agencies, as well as the cost template, which is not complete yet. They're still working on those rates for July. So there's not a cap from our perspective, but there is a approach using national labor information that provides a range of what most folks are making within a CCBHC setting.
Okay, and then I'm looking at, thank you, Commissioner. I'm just really struck by across all of those lines, the 6 million lump sum and provider rate increases. And then in our contracts, just for WellPath at DOC, 5.6 million increase.
Well, PATH is general fund. These are all a combination of, and this is the general fund portion of that. These are plussed up significantly,
Almost double.
almost double.
Okay, the slide I'm looking at is slide 11. DOC WellPath, second line up from the bottom.
It's general fund, yeah. And so it's 5.6 million. If you're
Right.
comparing the two of them, that's a gross cost. These are the general fund costs.
Yes, but both are. It looks to me like we're using 6 million of general fund right here for all of those 5 different line items for provider increases. On slide 11, it looks like we're using general fund, 5.6 million just to increase WellPath providers.
But it's an increase in the total number of individuals who are currently incarcerated. It does include, the other component of it is annualizing the substance use and mental health treatment in our correctional
I
facilities.
hear you. It's
interesting.
It's incredibly shocking that across all of those providers, it's almost equal to what we're increasing for healthcare services that are done by a contractor for incarcerated people. I just see a deep inequity there, but just wanted to underscore that.
Commissioner, did you want to weigh in?
I was just going to, I think, regardless of who was providing the services within DOC, that would be what it is, even if it was a designated agency or somebody else, because it is straight general fund, they can't bill for any of those services. So that is the effort in providing those services within that segment. But that's a limit that we have within all of the criminal justice system, is that you cannot get Medicaid. You cannot bill what typically would be a reimbursable service inside.
Yeah, I understand. My point is that we would love to see that money that's going to WellPath go to these providers who are Vermont providers who are treating people potentially in upstream services. And they're doing a great job at it. They just don't have enough money.
I hear you.
They don't end up in KOC
DOC
custody, where we are now paying WellPath. All general.
Okay, now we'll give an overview of the areas of savings that we identified in this budget. Here's the breakdown of all the categories, and we'll give a brief overview of each of those categories. And I will say, Tasha, I will follow up with another document that would be handy for this group. It's a 1-page, or it's actually 2-page summary that lists all of our ups and downs. It's not the old, we still do the old ups and downs format, but this is just a more condensed version that's broken down by department. It's kind of easier to find information.
I'm sorry, listen, could you also update this slide or provide somewhere what that gross up is? Okay, thank you.
Yeah, that's what
Okay, so in the revenue category, we talked about this earlier, the new adult. So just based on the utilization, we are able to get 90% FMAP on that group. And so that's $3 million general fund saving. With expanding to the additional 5 CCBHCs, that is also at an enhanced match rate. So that's a savings of $6.6 million because we will be earning more on the federal side. There's a $1.5 million revenue adjustment in the substance use treatment program. And then at DMH, they are going to be able to, they're projecting to be able to bill more Medicaid because of lengths of stay that are under 60 days that are actually Medicaid eligible. And then for DIVA, there will be a prescription drug copay increase that equates to about $461,000 general fund, and that is a requirement coming out of HR 1. I'm sure Deshawn will speak to that later. Did you see that? I went down and it went up. Oh my gosh.
Challenges today.
Computer does not like me today. So we have caseload and utilization in a few areas. one being at Rutland Regional Medical Center, the level 1 beds, 718,000 general fund, and some caseload with DCF and Reach Up and substitute care. And then with Dale, the adult day health and rehab services, $419,000. We're seeing less utilization there. We have identified a $7.3 million general fund in efficiencies. All departments sharpened their pencils, looked at prior year expenditures, and right-sized the budgets for travel, equipment, supplies, and fleet. So that's $811,000 savings. DMH and DOC savings, $6.1 million. We showed you the slide earlier that shows the current vacancy rates. And so we felt it was within the budget or within the amounts that are vacant, that this is achievable. It's not that we are trying to reach target. It's just, there's still room for DOC and DMH to be hiring, but we felt this was comfortable based on.
More closely aligns with
Yeah.
our recent experience.
Correct. And then the 314,000 for Dale, other personal services is really just a technical adjustment.
I'm sorry. The DMH level 1 at Rutland Regional, did we hear about that when you? Okay, I'll go back and look at your slides. I'm sorry.
These here are caseload and utilizations. So what we did was we took a look and we said, what is our current caseload? What is our current utilization? This matches what we have seen as historic caseload and utilization at Rutland. It's not to, if for some reason we saw an increase in caseload in any of these areas, we would be back here in BAA making a request. So this just makes an align.
No, I understand. I didn't remember that.
It was in the list of the reduction conversation that we had, but
It was also enthralling. I just missed that one. Tucker, did you have a question?
Yes. Department of Mental Health and Department of Corrections are saving $6 million. What percentage is corrections and what percentage is Department?
We can get that back. We can get that back to you in terms of which percentages, but what these are simply reflecting is the current vacancies that we have seen and the historic trends. The good thing is, in both cases, since the pandemic, we have seen a significant reduction in the total number of vacancies. As we came out of the pandemic, the hospital had close to a 60% vacancy rate. They're down in the 30s at this point. But given the current situation in healthcare, and it's not that those positions are vacant, at least in the hospital, we're able to cover that with travelers. And so that's where you saw the traveler cost increase.
So out of that, DMH is about 3.3 million of that and 2.7 is DOC. Okay, sorry. Okay, programmatic efficiencies. So the school-based services program is currently run out of the Agency of Education, and our agency and education have been working closely to transition that program over to DEVA. And so by transitioning that over, we think we can achieve $450,000 in savings at the Department of Vermont Health Access. DEVA is going to institute additional utilization management for durable medical equipment. The applied behavioral analysis coding compliance, that was also in budget adjustment. At DMH, we're proposing to reduce the number of beds at BPCH from 25 to 21, and that's based on actual experience. Of the whole wing has been closed for a significant.
That's based on caseload.
Can I just, I see you, Topper, are we gonna talk about the utilization management for DME?
Yeah. Yes.
Okay. I'll save my questions till then. Go ahead.
Does, what does the dropping 4 or 5 beds from the hospital, psychiatric place, what does that do in terms of Medicaid reimbursement?
That's an interesting question. So the reason we have not had those beds open since before the pandemic. So at this point, this reflects the current utilization in the system. So this will not actually change the overall mental health system, what that means is that it'll end up just reflecting what the actuality is. If you're referring to the 16 beds, are you referring to the 16 beds IMD? This does not get us down to the 16 beds, so we will continue to have the IMD phase down.
And the last item is,
And that's because those beds are actively used in our system.
That wing there where those beds are, wasn't because of trying to get people to work there, why that was not utilized. Is that correct?
So coming out of the pandemic, I would say that at a 60% vacancy rate,
Yeah.
it became very challenging for us to staff that wing. At this point, what we've been monitoring very closely is the capacity of the system. How long are people waiting for treatment?
Yeah.
And that's leveled off. I'm not saying that some individuals don't wait. There are individuals who have very medically complex situations who often wait in an emergency department. But for those who don't, the wait times have dropped down to a rate in which matches or is better than what we saw pre-pandemic. And so we feel like the system flow and working with the hospitals is working at this point in time. And so this reflects what we think the capacity is needed in the current system.
What we keep hearing, that people are waiting in lines in the hospital.
Happy to bring you the data on that would demonstrate that the length of time that individuals are waiting is not lines of people out the door. So we have data on that. I actually look at it every week in terms of the wait time for voluntary and involuntary. And it's gotten down to a point where why don't we bring you the data?
Yeah.
It's gotten down to a point where, I don't want anyone sitting in a waiting room for 3 or 4 days, but that's not what's happening anymore. Unless someone is very medically complex. And again, Brattleboro Retreat and VPCH it cannot serve those who have medical conditions. They're not a hospital, they're psychiatric hospitals. And so spaces like Springfield and the other hospitals that can provide both medical and psychiatric treatment are the places that individuals
So
are most
that's
often
why
transferred.
we don't need as many beds in the psychiatric hospital up on the hill. Okay.
not to use that button. Gosh. Okay. So we have a list of program and service reductions and eliminations. In totality, there were about 38. And again, this one page, the summary that I'll provide after will lay all those out. But here are a few that we would highlight for you. The total is 9.9 million general fund. The first one is actually in the secretary's office for refugee transitional housing. A couple of years ago, $900,000 was built into the base to support refugee transitional housing. But due to the decrease in the amount of refugees arriving, this is really underutilization. We are receiving about 75% less refugees in the state, projecting about only 100. So $400,000 will remain in this program, and that will be to use for some transitional housing, but more so on support services with case management, legal services, employment services. That's why we propose this reduction. DEVA, Vermont Legal Aid, Medicare Assistance Contract. DEVA will speak to more in the next session, and also the ACO per member per month payment, since the ACO has now sunsetted.
Just explain what this.
Oh, the legal aid. So that is that contract was to for Vermont Legal Aid to assist in doing coordination of benefits with Medicare, and the amount that we're seeing through Medicare is actually less than what the value of the contract is. And the statute actually says the contract can be canceled if it's cost inefficient to maintain that contract.
It's intended to support the drawdown of Medicare funds,
Which one are we talking about?
the second one.
The second one.
Oh, legal aid.
So Legal Aid has a program that helps us recoup funds from Medicare. The statute says that that program actually has to cover its own costs. And at this point, the amount of revenue that's coming from that program is significantly below the amount that the program actually costs.
Last year, I believe you had bridge funding for the ACO. Is that the per member per month we're talking about, or is this a different per member? Per
Yeah,
month?
so the ACO went away and they provided a per member per month to two practices as a part of their overall program. I would say that the goal here is this one will sunset because it was a program through the ACO that we couldn't reset. But through the Rural Health Transformation Funds, you will see significant investment in primary care and other providers on the ground that will surpass this $2.1 million.
So this is not, because there were multiple per member per month programs through the ACO. This is the one for the large payment that went to a couple of practices. I can't remember what we call
Deepak can get into this one a little bit more detail in their budget. Again, these were I want to reinforce from the top, these were very difficult decisions that we didn't take lightly. They were not made by one department or the secretary's office. They were made by the joint decisions of the executive leadership team. They were based on a review of programs that were sunsetting, a review of programs that were not performing, where there was duplication. And so I do want to reinforce that again here. I think it's really important. These were not decisions that we made lightly. Are there any questions about any of these specific? And again, there's a list of 38 programs that we saw that were either eliminated or reduced.
Go ahead, Leslie. Oh, yeah, could you switch to the AHEC program?
So the AHEC program is a loan repayment program. Folks will note that loan repayment is done by both VSAC and by AHEC. And so this is a program that is sunsetting. It was a very difficult decision, but in terms of looking at the overall outcomes and retention of providers in Vermont and the duplication with VSAC, we had to make a difficult choice to eliminate this program. That said, Rural Health Transformation, while it cannot, it's prohibition at the federal level, loan repayment, there's significant investments into workforce, particularly things like tuition reimbursement for health professionals.
So will there be a gap? I think we also saw that there was VSAC also a cut. I'm not seeing it there here, but I think from VDH, there was a VSAC cut.
This education repayments through VSAC.
Okay, so those two cuts. And of course, workforce is a priority. And I hear that you're saying that the transformation money should fill that gap, but there's going to be a gap. And what about the people that are already in the program getting support?
They apply every year. And so this isn't a program where individuals are getting a guarantee set of funds on an annual basis. And we had to make some very difficult decisions. And we cannot do a loan repayment program through Rural Health Transformation, but there are significant investments into workforce programs in it. I don't remember. We can come back with an outline of what the total amount is. They are things like tuition payments for current students. Again, doing the same things. These were programs that were difficult to make decisions about. We did look at data and retention of providers here in Vermont. And so based on that data, had to make some very difficult choices.
I understand. I mean, you say many times difficult choices, but those difficult choices have implications for individuals that we're trying to support to
There's no
build
one
our
in-
workforce. So I'm just concerned that we're going to be leaving people in the lurch. I understand. I heard you say you have to apply every year. However, people start a career and they start their schooling based on some assumptions, which are now being removed. And what is the plan? I don't imagine that your workforce through the transformation money is gonna be up and running immediately because that's hard.
It actually is. It
So are
actually,
you saying that that's gonna fill this gap? These particular state
it's not going to do loan repayment. I want to reinforce here again, and we probably should move on, and would be happy to come back and speak to this. But this program is not a program where someone goes to school and is guaranteed when they go to school that they're going to get $10,000 a year of loan repayment. It's not for an individual who got loan repayment last year. It's not an expectation that they will get loan repayment again the following year. That's not the way that this program actually works. And so we're not taking funding away from an individual. I do hear you. And we have, again, to make some very difficult decisions. The rural health transformation programs have to be up and running this year. $195 million has to be obligated in this year and has to be out the door within 18 months. And so those programs will be up and running, or Vermont will not get that funding again.
Okay, but this particular cohort that's already in training.
This particular cohort was not guaranteed any funding.
I understand that. I hear you. However, there is this, sort of support of the workforce development. I probably should go on. I get it. But I do feel like we are abandoning a cohort of people.
I hear you.
I'm very worried about that.
I hear you.
Lori.
So, I appreciate that hard decisions were made and we still have to do our work.
Yes, you do.
And the commissioners who have been so far, presentations have been great, but I feel like there's been a real lack of data behind why these cuts are being made. And so in the beginning, you mentioned that you all looked at data, you asked some really good questions. We need to see that data for these programs. And so, Chair Black, we work as a team of a couple of us that work on the budget, and we're putting together letters to go out to the commissioners on what we're looking for. But I am just going to say right now, we want to see the data behind these. And then we also want to understand what the statewide strategy is, right? You said there's duplication. So if we're losing something somewhere, how is it being taken over and how is that service going to be absorbed into whatever?
We would be
strategy you have?
excited to come back and share the data. We don't have the context and the amount of time today to do that.
No, I understand. Yeah. And what we would like to do is actually have it in writing and then come back as needed.
We can do that.
Okay, thank you.
Brian, did you have a question?
I'm gonna let it go because we really need to get through more stuff.
How about
Okay. And then we would want to highlight the initiatives that we are proposing. So we're seeking $31 million between base and one-time funds to support sustained investment in emergency housing. So 10.1 million for family-specific domestic violence and medically vulnerable shelter options, a substance use recovery shelter, case management enhancements, rental assistance and staffing, and then to continue a portion of the regular GA program. Then we also are proposing to fund the opioid recovery employment program through Dale's Hireability division, and that's $875,000. That was previously funded by the opioid settlement money. But that was not recommended, is my understanding from the committee. And so this is another program that has offered good data on effective outcomes. So we're seeking that in the budget. And then expanding the DOC pretrial supervision statewide. We need $200,000 in order to fund a probation and parole officer in every office throughout the state. And then I'm not sure if we have more time, but the rest of the slides are really just digging into the central office, what we provide for services in the central office. If you want us to keep going.
I'm just looking ahead at your slides here.
I'm curious about the refugee program. Are you seeing any strain in that area, considering that many refugees are being targeted for money right now? Like we just heard, one was detained recently before his ICE appointment or whatever. So I don't know if you're seeing any extra stress there.
Yeah, the refugee program provides supports and services for refugees who are currently here, including things like housing, helping to get folks connected with employment services. What we are actually seeing is a decrease in the funding that's needed for the program because we're not seeing as many people come to it. Again, the refugee program would be happy to come and speak more, but no, I don't think that, I think that overall the stress level is very high, the financial burdens.
There's a social cost, but not an economic cost. Thank you.
Lori,
We did 1-year bridge funding for SASH for ahead. That is not happening at least this next year. So is SASH funding still in this budget?
SASH funding is not in this general fund budget, but what we are looking at is funding. There's two things that, so as a reminder to folks, when CMS, when the all-payer model, we exited that. And before ahead or another model comes up, there are Medicare programs like SASH, which is serves primarily only Medicare beneficiaries, and the blueprint portion of the primary care payments that are Medicare portions. Those we are looking at, they are Medicare funded. We're looking at how we can support them in the rural health transformation.
But there is no solid as of right now.
They are written in there is a plan for them in the rural health transformation hubs.
Can we see that language?
Yes, Jill Olson, Medicaid Health Systems Director. The language is pretty general in the Rural Health Transformation Fund as we wrote it. There's a whole series of sections on the blueprint and the blueprint payments. So I'm not sure it's actually gonna sort of eliminate it for you in the way that you're asking, because we were intentionally open-ended in some of our descriptions. So I think there is some more work to do with Cathedral Square to sort this out, but that is our plan.
And again, this is a Medicare
in Chittenden County.
Yeah, they are the operators, actually. They're the.
I thought we couldn't use any of the rural health transformations in Chittenden County.
So SASH is a statewide program. The administrator of that is Cathedral Square. There's some nuance in the rural health transformation funds. If those funds support are supporting services that are delivered in rural communities to rural Vermonters, we can use those funds. So whilst Cathedral Square is a provider in Chittenden County, the majority of SASH is delivered in the rest of the state outside of Chittenden County. Again, this is a Medicare program, and until we are in another model that includes funding coming in from Medicare, this will continue to be a challenge. The ultimate long-term plan was to, if we go into ahead, it is funded under the ahead model.
Where are we on ahead? And then Lori.
Can I just stick with SASH real quick?
Oh, yeah.
So when, obviously a big concern that July 1st comes and there is no plan.
There is a plan.
When would this, if we don't have SASH in the budget, when would the SASH end?
They have calendar year funding, bridge funding is through this calendar year, so the problem starts on January 1.
Of
27.
27.
Yeah.
Okay, that's helpful. Thank you.
Karen, and then how's everything going with ahead?
The simple answer to that is we've just, with the new administration, we need to start negotiations on the ahead model with some updates that they have in the model. We've just started that, so we can provide that more information in the coming months.
Right. Okay, Karen. Yeah, I just wanted to notice the SNAP shift from 50% to, is that permanent? Or-
Yes.
And there was no transition for that.
It was something that came out of HR1 and a major change. So it was as soon as HR1 was implemented,
Effective October 1st.
the federal fiscal year.
I'm sorry, one last question. And this, I know we're putting a lot on you, so this doesn't have to be like an immediate thing, but it would be really helpful to have one page that shows truly where the lack of federal funds from HR1 or any other actions, not like the FMAP one, but how it's affecting AHS. And I don't need a lot of detail about the program and the amount that we're losing.
Okay.
Would that be available? Could that happen without too much?
We can make that happen.
Okay.
Things like SASH though will not be on there.
That's fine.
It's not anything to do
Yes,
with.
yeah,
with the-
but like the SNAP and yeah. Thank you.
And I think the Secretary of AOA actually has that for everybody.
Oh, then we could just ask that.
Correct.
Okay.
And presents that to the joint fiscal joint.
Okay.
Any other, do you want to keep going or any other thing?
I don't think so.
Okay.
We can.
Thank you. We appreciate your time today.
Thank you. Thank you. All right. Let's move on to Diva.
Before we move on, can I just say I looked ahead and I want to acknowledge that you didn't cover some accomplishments. Like I see that you mentioned some accomplishments. I want to acknowledge that I'm seeing that.
Thank you.
I mean, we were critical, so it's no strength.
And the back and forth on the budget. I just want to be really.
Okay.
Yeah, we've had to make some really difficult decisions, but I think the budget review process is important.
Let's be gone.
The fact that we did it together made it. That's great.
What's that?
The fact that we did it together.
Commissioner, maybe you can speak to that.
Okay.
As we make the transition.
I'm actually going on the commission for down of the day that we had living. Us doing this in terms of here can made a huge difference. In terms of us all being on the same page and being able to cover things across the agency.
Is that the first time you did that?
Like that, yes, absolutely. Big improvement. Yes.
Sean, you want to come up? I'm sorry. Commissioner Groves.
Stay around.
Okay.
You got it?
Yeah.
You don't have to sit around. I mean, I'm open, but just.
I don't have an indication, but who do we have on Zoom with us today?
You should have Allison and Rachel Stilwell.
I'm sorry, I didn't have. Hi, Eddie. Rachel. Is Alicia not with us? Oh, there's Alicia right there. We're still live, everyone, just to let you know.
I'm just blowing my nose in the hole. It's gonna be loud.
Welcome. So let's start in. Although I lost half my committee. I'm doing it. Okay. Oh.
Okay.
You can go ahead and start whenever you're ready.
All right, good morning. I am Deshaun Groves. I am the Department of Vermont Health Access Commissioner.
Morning, everyone. Alicia Cooper, Director of Managed Care Operations for the Department of Vermont Health Access.
Good morning, Addie Strumlow, Deputy Commissioner at DEVA.
I'm sorry, Allison, we're having a very hard time hearing you.
Is this any better?
A little bit better, yes.
Get closer to my microphone. Allison Novak, Financial Director in the DEVA business.
Thank you.
Hey everyone, I'm Rachel Stilwell. I'm a Financial Director in the DEVA business office.
Thank you.
We're missing Alex McCracken. I see where she is.
Usually right in that corner.
I know.
There is extra security today, so.
Oh, that's true. Once in a while I see her over there, so. Did that corner or?
Yeah. We have.
Do we want to start or does she have slides?
She had slides.
Oh, she has slides.
She had the slides.
Should we take a break?
I think we should.
Let's take a break.
Okay.